How's everyone doing this morning?
Good.
Excited about Friday, a weekend where maybe we shouldn't be doing anything too adventurous if we're going to be having a nuclear winter this weekend. Does anyone have any big plans?
Driving to Spokane, so I'm really hoping that highway doesn't get closed.
Yeah, it's really awful out there.
Might go apple picking.
Oh, that sounds nice.
I got permits for the enchantments, but I don't think that's going to be happening.
Oh, that's sad. It's such a beautiful area up there.
Yeah.
Yeah, but probably not a good time to be isolated in the middle of a forest, out of touch, out of range.
Yeah, I was like, would we just burn? Like, I just don't even understand.
Find yourself a lake, get in it, we'll hope for the best.
Exactly.
Yeah.
Hypothermia or, yeah, cool. Great options.
I know that the fires that are happening on the West Coast are really devastating right now. And, you know, some people might be personally affected by that. I grew up in Medford, Oregon, and the town just to the south of where my mom still lives just completely burned to the ground. She was within 1 block of the evacuation zone on Tuesday. And of course, as these things always seem to happen, it's the poor communities of color that have been devastated, and the people who have yards and space around their houses have been fine. And it just seems so awful and unfair. And so I've been thinking a lot about that, but I'm imagining people who have loved ones anywhere up and down the West Coast are impacted. So just know that I'm thinking about everyone and hoping that your family and loved ones are safe. And with that happy news, I will start talking. We're going to start today with prescribing a new medication. And I'm sure all of you have had the opportunity to prescribe a medication so far during your residency, both in the inpatient and outpatient setting. And something I really never gave 2 seconds of thought to when I was in training was how to do this right. I sort of was like, well, you write the prescription and the patient takes the medicine, and that's how you prescribe a medication. But thinking more about it and reading more about it, you know, I'm sure you're probably all not surprised to find out that like half of the prescriptions that get written never even get picked up. And that patients stop their medications all the time without checking in with us about it. And when you're in the hospital, you know, it's easy. You tell people to jump and they say how high, you know, that's you prescribe the medication and the nurse hands it and puts it in their mouth. You decide how much they pee, you decide how much they eat, you decide when they poo, you decide everything. But when you're in the real world and in primary care, you know, the onus is on the patient to be making these choices for themselves. And so there are ways that we can prescribe medications that are going to enhance adherence and reduce the risk of our patients not understanding what's going on and also deciding, you know, sort of without talking to us, not to do the thing that we thought they were doing. So and the other thing that I think about a lot now that I didn't have insight to when I was in training was the fact that like pretty much half of what I learned during medical school and residency is like blatantly untrue at this point. And, you know, everyone said that was going to happen. And I was like, that's not going to happen. Like science is way too advanced for that. But I mean, the way we treat cholesterol, the way we treat hypertension, the way we treat diabetes, like all these things that seemed pretty tried and true when I was training, everything is different now. And that's cool. That's an exciting thing about medicine. But the things that haven't changed are the sort of fundamental core skills of like being a human being with another human being. So if you're going to develop anything during this time, it's probably not memorizing medications and things like that. That stuff you can look up. It's the like so-called soft skills that are going to be sort of fundamental to your career that you want to really embed into your heart and soul at this point, because those things won't change. I hope they'll change if you become hardened to all of this, but the goal is not to let that happen. So I'm going to share a screen. My goal is to learn how to share a screen without making the Zoom squinty face. Haven't totally accomplished that goal yet, but I'll try. Okay. Are you all seeing the PowerPoint at this point? You're gonna like nod, a vague nod. Thank you, John. I appreciate that. You're the person I can see right now. Okay, so we're going to talk about how to prescribe a new medication. Then we're going to pair off into into pairs, obviously, groups of 2. And you are going to practice prescribing new medications using the sort of steps that we are outlining here. And it's going to feel a little bit repetitive and silly, but it's planned redundancy. So this redundancy of making you do this over and over and over again is really just to make it a little bit more automatic for you. Why aren't we forwarding? Okay, so our learning objectives today are to review the steps of safely prescribing a new medication and then practicing counseling on prescribing a new medication. So this was published back in 2006, which feels like a lifetime ago, but seems to be still pretty standard recommendations and advice. When you are counseling someone on a new medication, you want to tell them the name of the medication. And this includes the brand and generic. And if you don't know that, you can look it up. And I often don't know what brand names are. And I have to look it up, and that's fine. But you will be surprised how often you're talking about amlodipine and the patient has only heard Norvasc and they think they're not taking that medication, or they just aren't familiar with what you're talking about. So we might have a cameo from my son here soon. Oh, he brought me chicken nuggets. Nothing says Friday morning like chicken nuggets. Delightful. You want to share the anticipated effects of the medications. This is what you're hoping it will do. This is a medication to lower your blood pressure. And then the adverse effects. So rarely, but commonly enough that I want to talk to you about it, people experience some swelling when they take this medication, this amlodipine medication. How long to use the medication. This is a medication I anticipate if we tolerate it okay, you're going to be on it indefinitely. Or this is a medication you need to take for 5 days and then stop. Or this is a medication you need to take for 6 months and then stop. The number of tablets to take. So make sure you're really specific about, like, you're going to take 1 pill in the morning and 1 pill in the evening. Because even though I feel like I do a adequate job of this, I often have people come back and be like, oh, I take 2 pills in the morning, even though it's supposed to be a 1 tab BID kind of situation. The frequency and timing of the dosing, and then make sure you do a teach back so that the patient, you're sure that the patient understands. So I think we talked about teach back before, but if we haven't, then we can talk about it now. It's basically just saying, I want to make sure I did an okay job explaining this to you. Can you tell me what the plan is so that if there's any misunderstanding between us, we can correct it now. All right. Does that make sense? Any questions about any of that? Comments, concerns?
Can you hear me?
I can hear you.
Oh, I had a question about the number of pills. I feel like sometimes I've run across where you prescribe like 20 lisinopril, and then the pharmacy will dispense them to 10 milligram tablets instead.
Yeah, that can be really hard. And alternately, at the VA, it happens often that I'll prescribe like 25 of metopsuccinate and they'll give a 50 milligram tablet and tell them to split it, right? Because they want to save money. So sometimes I also say, the pharmacist might change this a little bit. So make sure you read the label really carefully. And if there's any questions, let me know. Because oftentimes there will be like cost savings measures like that. Or I'll prescribe something like there's a 30 I want someone to take like 30 milligrams of a medication, and instead of giving them a 60 to split, they'll give them 3 10s, so all of a sudden like the doses are way off. So reading the label really carefully is also really important. That's a great question. What other questions do you all have?
I don't know if you're going to get into this, but obviously, like doing this well takes a ton of time, I think, or it feels like it might. And then I feel like I've been told before we can, at the VA, refer to our pharmacist or nurse to help teach for new meds. Is that something you take advantage of? And
Yeah, that's a great question.
how do you balance like doing it yourself versus delegating the task?
It feels like it might take it when you look at the list, it looks like, gosh, that should take a lot of time, but actually it doesn't take a ton of time. It's a couple of minutes maybe for a prescription, and hopefully you're not prescribing 10 new things in one visit. So it shouldn't take too long. And yes, the pharmacist, even if no matter where you are, the pharmacist should be able to counsel people on the new medications. So you can tell them to talk to the pharmacist. The patient can always refuse that when they get to the pharmacy. They can say, I don't want the counseling or whatever, but you can encourage the patients to take advantage of that. Yeah, and so thanks. There's some comments about Epic, and then the comments about what's cheaper or what they have in stock. So that's all true. So yes, pharmacists are outstanding resources, and most clinics have pharmacists available either by phone or in person. And then retail pharmacists actually are also equipped to do this counseling if the patient doesn't decline it. But I would give it a try when you're prescribing a medication. At least tell them what it's called, what you're giving it to them for, what side effects they might have, and when to stop. Because otherwise the patients often aren't going to pick it up. Okay, so Whitney, if you're there, are you able to put the PDFs of the situations in the chat? So we're going to put all the cases in the chat because once you go into breakout groups, you can't see the PowerPoint slides anymore. So once we do that, please open the PDF so that you have it on your screen, and then we will get a little thumbs up from y'all, and then we'll put you into your breakouts. It is currently 8:18, so we'll do this for 20 minutes and come back at 8:38, and then talk about how we feel for about 10 minutes and how that went, and then we'll take a break. Does that sound good to everybody? So 20 minutes, you have a certain number of cases. Let me see, 1, 2, 3, 4, 5, 6 cases. So that gives you about 3 minutes per case. If you want to go more slowly and do fewer cases, if it feels like that works better for you and your partner, that's fine. You are adult learners. I want you to feel like you can do what works for you. The other thing is, this is not a quiz on how well you know these medications. So please look it up. If you don't know the answer, pull up the UpToDate or whatever Micromedics or whatever resource you like to use. You can absolutely have that open. So because the point of this is not memorizing the medications, it's learning the steps. Does that make sense? Okay. All right. So Zoom away, and we'll see you back here in 20 minutes.
Did you see my chat about the cases? Because we didn't get the cases at all, and I don't know if anybody else did.
I did not get your chat. I sent the cases in the chat before I opened the breakout groups. Do you not see them in the chat?
I saw them in the chat, and we had asked to click on the PDF before we went to breakout groups at 8:17 a.m.
For whatever reason, I didn't get it in mine, and yeah.
Oh.
Huh.
I got it and was able to download it but it was there just for a brief period, and now it's not showing up, so I'm not sure why that is.
I wonder if the chat erases when you leave and come back, because I still see it. So in the future, if that happens, you can leave your breakout room, and because we're here, and we can give it to you again. I'm sorry you had that experience. That's too bad.
Oh, no, it's okay.
Did you practice prescribing new medications anyway?
Say what now?
I said, did you practice prescribing new medications anyway?
We just talked about like factors. I guess I'll just start, huh?
Well, let's wait till everybody gets back. I actually don't know how many people are. Is everybody back?
Everyone's back.
Oh, okay. Did everyone else get the cases? Okay, great. So yeah, let's start talking about how that went. I'm sorry, there was a pair that didn't get the cases before they disappeared into the Zoom breakout group. Wonder if people can kind of reflect on how that went, what was easy, what was hard, what you need to practice, et cetera, et cetera.
I feel like I need to practice just knowing what are the most common side effects. Because like if you look it up, there's always like a bazillion listed. And obviously I can go through that, but I only know anecdotally what are common side effects.
That's a really good point. And a lot of that comes with time and experience, which many people don't have yet. So one thing you can do to mitigate that right now is talk to your attending when you're staffing and say, hey, I'm prescribing this medication. I want to make sure I go over side effects. What are the most common side effects for whatever this medication is? Because I haven't prescribed it that much. And they'll be able to tell you.
Yeah, Marina and I used Micromedics when going through some of this, and it was kind of nice because it was pretty streamlined in terms of the finding kind of the components that we wanted to integrate into the discussion. So I definitely think I can implement that into my practice.
Great. Micromedics.
I think one of the harder things to find was the anticipated effect, like how much your blood pressure would go down or how much your cholesterol would go down. It was kind of like arbitrary that it would.
Yeah, I think that's a good point. And I think I should specify, I don't think you need to get too granular about that, but just so that the patient actually knows what the medicine is for, because I know that this probably sounds ridiculous, but it is totally frequent that a patient gets prescribed a medication and has no idea what it's for. And when you do a good med recon, I'm sure you've done this when you admit people to the hospital, often people don't know what they're really taking or they don't know why. And so just saying, this is a medication to lower your blood pressure, or this is a medication intended to reduce your risk of having a heart attack or stroke. And, because oftentimes people's numeracy isn't great anyway, so saying it's going to lower it by 30% is probably not a meaningful number for people anyway. So I think just the basic, this is a medication to help reduce pain and swelling, or this is a medication to help prevent pregnancy, or whatever the mechanism might be. But I think that's a great point, Marina.
One of the things that I'm not good at because I was not trained here is the brand names.
Mm-hmm.
And is there a way to know, for example, my clinic is at the VA, and a way to know what specific brand name is used on CPRS in our pharmacy?
I actually don't know that. That's a great question. And I'm also really actually terrible with brands because I grew up in the VA and we only use generic names. And so I usually Google the generic if I need to know the brand, and like the brand name will pop up, the one that's most commonly used. But there are some situations where there are multiple different brand names, like with birth control pills and stuff, like the exact same birth control pill is marketed in like 27 different ways. So, but for the most part, I will, if someone's like, is this the thing that I saw on TV? I'll be like, I don't know. Let me Google it and see if that's the thing you saw on TV, because I don't watch Fox or whatever that you're watching. And that's how I do it. It's not very scientific.
I would bet
Also,
my patients, if they are taking a medication by its generic name, and they'll be no. And then they just know only the brand name.
Mm-hmm.
Micromedics actually has a section called drug name info that lists the US trade names on it.
That's good to know. Thank you, Lauren. Yeah, because on Up to Date it lists it too, but they'll list like sometimes, you know, a half dozen or a dozen different trade names. Yeah, so Micromedics, good resource. Google, also fairly reliable if you just Google what they say or Google the medication you're thinking about too. So compared to your usual practice for the past month of prescribing new medications, how different is this? Do people feel like they're generally doing most of these things anyway? Or is there any piece of this that feels additional or different?
I feel like I was. Go ahead.
Oh, sorry, Ken. Thanks. I've been discussing, you know, why we started it, you know, kind of why we've been starting a medication and kind of sometimes things to watch out for if there's like something big that really stands out, like a statin or something to me, those side effects. But otherwise, I haven't been going into detail about, you know, how often to take. I guess I kind of always thought of that as like, because sometimes the dosing can vary based off what I prescribe and what the pharmacy provides. I hadn't been doing that, so it's something I'll have to add.
Yeah, I was just gonna say I don't think I got so granular with the information I was giving with patients about exactly that. And I would usually tell them how many milligrams I was starting them on instead of like how many pills they should be taking, which probably is not all that meaningful to patients.
Yeah, but I think the point is well taken from the earlier conversation that sometimes the pharmacy will change the number of pills. So yeah, I usually say you're going to take one pill twice a day, but please read the bottle because sometimes the pharmacy will change that a little bit. Yuri, you looked like you were going to say something.
I was just going to say, I have not really been doing the teach back. I've always sort of just been like, well, what questions do you have for me? But I think just remembering to kind of do the teach back is super helpful.
Yeah, teach back is clutch. You know, what questions do you have is also a great thing to ask people, and I think super important, but you know, people can still hide intentionally or unintentionally that they don't understand something. And so teach back is important. I think finding the right words for teach back can feel really awkward for people. It feels like this is condescending, or I'm insulting my patient, or I'm making some assumptions that they don't understand. So I think, you know, sort of playing with the language a little bit and figuring out what feels comfortable for you. But I try to put it on myself as like, I want to make sure I've done an okay job explaining this. And if I haven't done a good job, that's on me and I need to do better, right? And that way I'm not sort of putting any of the blame on the patient if there's a lack of understanding about what happened. All right, what other questions do you have?
I have a question about what you mentioned earlier in terms of the pharmacy dispensing a different amount or a different type of tablet. Is it on them to then tell the patient that that's what the change was?
Yeah.
Okay.
Yeah. Yeah, they should do that. But again, a patient can say, oh, thanks, I decline the counseling or the education or whatever and walk away. So hopefully there's enough sort of safety measures of you telling the patient, pharmacist telling the patient, bottle has the instructions. All right. So one thing that I wanted to highlight, which I am not sure has gotten highlighted very much with you guys since I was on vacation for the middle part of your guys' block, but is observations. Have you guys been having attendings or chief residents or senior residents coming in the room with you and watching you do part of your visits? Seeing some nods.
I kind of forgot about it.
All right, so basically before the holidays, you need to have 12 sort of confirmed observations. Obviously, I want you to be observed as much as possible because you're, it's hard to become an expert without a coach. And, you know, if you think about your life in sports or music or whatever else, you don't like rehearse without your conductor and you don't practice without your coach. So just thinking about your attendings as your coaches and people who are there to help you get from amazing to outstanding, because you are all starting at such a strong place. So basically, for prescribing a new medication, I want you all to have 2 observations of yourselves prescribing a new medication. It can be a telephone visit, a video visit, or a face-to-face visit. And after you have the observation, basically you just log it into MedHub as it yes or no question, did it happen? And all the attending does is click yes, it happened. So the feedback part of it, the coaching is on you guys. It's not something we're collecting. This is not supposed to be like an evaluation at all. It's just supposed to be a sort of formative experience. So make sure you get those done. If you're in clinic today, try to get it done today. And that's all I have to say about that. So we're going to take a 10-minute break now.